Thanks for coming today. I'm going to talk a little bit about post-traumatic stress disorder, and I'll be the first to admit that I did not know a lot about this. This is kind of stretching it for me from a trauma surgeon standpoint. So we'll kind of get started here because there are quite a few slides. I always like to integrate at least some of my partners into my talk. And with this talk, it was a little bit challenging just because there's not a lot of humor that I can do with this. So this is Dr. Hicksonball. Most of us all know him. And when you think of Dr. Hicksonball, you kind of think of this. You kind of think as far as a beach, it's calm, it's relaxing, there's not a lot of bad thoughts. And then there's one of my other partners. So this is Dr. Sheehan. And we all know that he's very intelligent. He's probably the smartest guy I know in regards to trauma. He's taught me a lot just in the last 5 years since I've been here. And if he doesn't know something, he's going to find out what it is. And just yesterday, actually, there was this new criteria that he was told about as far as for appendicitis. And he didn't know anything about it, nor did I. And literally the next day, he has a paper as far as the goods and the bads of what this criteria is to try to rule out appendicitis. So when you put someone this smart as far as with a directorship, as he is one of our trauma directorships, occasionally when you screw up, you get the letter. You get the trauma letter that you didn't do something right, you didn't follow policy or something of that nature. And then that oftentimes when you're the recipient of that letter, then that makes you feel like this. As far as you're sad, hopeless, angry, mad, something of that nature. And then that's PTSD. Okay? Any questions? That's my talk right there. So a little bit about PTSD. What we're going to do today is going to, first off, look briefly at some of the generalized anxiety disorders. We're going to look at the history of PTSD. We're going to look at some of the presentation and some of the signs and symptoms that people with PTSD have. We're going to look at some of the criteria on how do you diagnose someone with PTSD as far as, say, if you're a psychologist or a psychiatrist. We're going to look at the differential diagnosis as far as how do we kind of rule in or rule out if you do have PTSD, some of the prevalence, etiology, some of the risk factors of PTSD, and then finally some of the treatment issues. So first off, PTSD is grouped into anxiety disorders. So part of the anxiety disorders is going to be specific phobias. There's all kinds of phobias, coulrophobias, fears feces. If you're a general surgeon, you can't have that. Ergophobia, fear of work. More and more of society is having that fear. And then glossophobia, which is what I have, fear of public speaking. So another one would be panic disorders. And this is where you're going to have intense fear that triggers severe physical reactions. So you're going to actually have physical signs and symptoms of something that you're anxious about when there really is no real danger or any apparent cause. And then there at the bottom, you're going to see a lot of what you can get. You get rapid heart rate, sweating, nausea, trembling, chills. You can hyperventilate, abdominal cramping, chest pain, headaches, dizzy, etc. Then you have generalized anxiety disorder. Now, this is going to be excessive, ongoing anxiety, more or less about just life in general. It's a day-to-day activities, etc. Then you get into agoraphobia. And agoraphobia is going to be more where you have true anxiety and fear of going to certain places or getting yourself into certain situations. And you try to stay away from all that because that's going to give you feelings of being trapped, helpless, embarrassed. Certain examples of that is going to be public transportation, being either in big open spaces or closed spaces, standing in long lines. I have that in regards to Walmart. And then also being in very crowded areas. And then you also have obsessive compulsive disorder. So that's where you're going to have unreasonable thoughts and fears, which are your obsessions, that eventually will lead you to do repetitive behaviors. Say cleanliness. If you're the guy that washes your hands 100, 200 times a day, even though you know they're clean, you're still washing them every 15 minutes. And then also in the anxiety disorders, you're going to get the PTSD, which is what we're talking about. So what is PTSD? So PTSD is going to be an anxiety disorder that may develop after experiencing or witnessing an extreme, overwhelming traumatic event during which they felt intense fear, helplessness, or horror. So there's going to be some dominant features that you're going to look for. One is going to be emotional numbing, or where you basically emotionally you're unresponsive. You're going to have hyperarousal, where you're going to be irritable, or where you're always on a constant alert or stressed out. And then re-experiencing the trauma, where you have flashbacks, dreams, or intrusive emotions. Now, these can come on suddenly, or they can come on gradually over several months to years. So when did we first start to look as far as for what PTSD is? Well, it first was actually in the diagnosis books from the medical society back in the 1980s when the DSM-3 came out. So the DSM-3 is what psychologists, psychiatrists used to recognize and to diagnose mental health disorders. It was listed, though, as far as people describing it all the way back in the 19th and 20th centuries, back when they used to have some big railway disasters. Also was described in the Civil War. Da Costa, he labeled that as soldier's heart, which we'll look at a little bit later. It's also been shown up as far as, especially in the world wars. Oftentimes they would talk about shell shock, operational fatigue, or combat neurosis. This was oftentimes seen, especially with people that experienced the Holocaust, atomic bombs during World War II. Some of these labels then they would start to look into further. So the fright neurosis, or combat neurosis, or war neurosis, a lot of this is all going to be the same thing, to where it's an actual functional mental disorder that gives you a lot of distress. But you don't necessarily have any kind of delusions or hallucinations from it. It's oftentimes secondary to war or being on the battlefield. You're going to have signs and symptoms of anxiety, sadness, depression, anger, irritability, confusion, and an overall just low self-worth. You're going to have a bad or a poor ability as far as to try to adapt in the environment when you get out of wartime. You have an inability to develop a richer, more complex, or satisfying personality. Other labels would be shell shock. That's where you're going to be stunned, distressed, or exhausted from a prolonged trauma, oftentimes again in the battlegrounds. You're kind of in a state of dazed and confused. As mentioned, it's often in the wars. Survivor syndrome, that's also another one to where you have a large anxiety, more or less because you have a guilt of surviving. Say if your whole platoon kind of got bombed and you're the only one that made it. You relive this trauma as far as dreams. You have a lot of numbness, a lack of involvement of ever really wanting to get out into society. And then you have operational or combat fatigue. Now this is where you're going to have an immediate psychological and functional impairment that occurs in the war zones, battle again, due to severe stress or ongoing combat. And again, some of your signs and symptoms you're going to see is going to be restlessness, you're going to be withdrawn, confusion, nausea, vomiting. You're really always kind of suspicious of everything that's going on around you. So things like PTSD has been going on for a long time. It just wasn't labeled until around 1980. The last thing would be soldier's heart, as we talked about. This was in the Civil War. Da Costa syndrome is what they labeled it as. And these are going to be symptoms that are going to be similar to those of basically heart disease. You have real fatigue on exertion, shortness of breath, palpitations, chest pain, sweat, and nausea. But yet you really don't have any real physical examination as far as why you're having these signs and symptoms. So what are the criteria for PTSD? So the person's been exposed to a traumatic event in which both of the following have to be present. One, the person has to experience or witness or has been confronted with an event or events that's involved actual or threatened death or serious injury or a threat to physical integrity of oneself or others. And that's coming straight out of kind of the DSM-4. And then the other part of it is you have to have to be involved with intense fear, helplessness, or horror for that person. Now in children, it's noted a little bit different. They may actually express instead as just being disorganized or real agitated behavior. So to diagnose PTSD in children, it's a lot harder because there's so much verbal cues that you rely on to diagnose it in adults. So you actually kind of group three different categories as far as diagnosing a person with PTSD. One is going to be intrusive elements, avoidance features, and then increased arousal. In regards to intrusive elements, you have to have at least one of these symptoms to be diagnosed with PTSD. So recurrent and distressing recollections of the event, recurrent dreams of the event, sudden acting or feeling as though the trauma is going on or recurring, intense psychological distress at exposure to things that symbolize or resemble of what that initial stressful event was. This oftentimes can be like anniversary dates of the traumatic event. Physiological reactivity when exposed to internal or external cues of the event. So you got to have one of those to start with. And then you have to have 3 of the avoidance features. And these avoidance features are going to be where you try to avoid the thought or feelings associated with that original event. You try to avoid certain activities, places, people, or situations that may actually cause you to recall that initial trauma event. Inability to recall an important aspect of the trauma. This is oftentimes called psychological amnesia, to where you just simply forget. Markedly diminished interest in certain significant activities. You feel detached or estranged from others or from society. You have a very poor affect, difficult to actually be involved with your loved ones. And you have a sense of foreshortened future. So you don't feel like you're going to really make much of yourself in regards to your career, marriage, have children, or live a normal lifespan as though you otherwise should. Then you have to have 2 of the increased arousal symptoms, which is going to be having problems to sleep or to stay asleep. Irritable, outbursts, anger, which all this can progress to rage, difficulty with concentration, hypervigilance, where you're real paranoid, or you have a real startled response. And all these things have to come on after that initial traumatic event. So if you had a bunch of problems, sleeping or staying asleep beforehand, then those don't count. So to recap, you need 1 of the re-experiencing symptoms, at least 3 of the avoidance symptoms, and then at least 2 of the increased arousal symptoms. And on top of that, then it has to be going on for at least more than a month. And it has to cause significant distress or impairment of social, occupational, or other important areas in your day-to-day life in regards to functioning. So here's just kind of another list, the next 2 slides, just a big long list as far as symptoms that you should be aware of or that may lead you into PTSD. You have a lot of recurrent thoughts of the events, flashbacks, numbness, intense guilt or worry or anxiety, anger, feeling of always being on edge or hyper arousal, avoidance of certain thoughts, situations that may remind you of the trauma, spontaneously re-experiencing the trauma, being startled, phobias, in which this kind of leads into phobias as far as oftentimes PTSD, it's not just you have PTSD. You can be labeled a lot of times as far as having other anxiety disorders along with that. You can actually have physical complaints, problems with concentration, sleep, as we discussed. And then this is another kind of long list as far as other things. Fear of being in crowds, closed spaces, you're restless, always worrying, a lot of panic attacks or feel like you're going crazy, hopelessness, anger and rage. That's a really big one because that can really cause a lot of problems to keep people then in society when they get out of, especially like wartime, to try to fit, our soldiers back into society. They have a lot of issues as far as with anger and rage to try to keep a job, etc. Irritable, difficult to relax, problems with your schedules, trying to, you have a higher rate of absenteeism and things like that. A lot of shame or guilt, embarrassment, isolation. You kind of just shut yourself off to the world. You don't show your normal emotions where you're doing kind of that 1,000-yard stare a lot. You kind of alienate yourself from the rest of society, over-controlling, and then a lot of people get into addiction issues as far as drug, alcohol, etc. So some of the types of PTSD, you can actually have acute onset or chronic onset. So if you get your symptoms within 3 months of that traumatic event, that's going to be considered acute. If it's more than 3 months or if it's several years, then that's going to be considered chronic. Acute is easier to treat. Chronic is harder to treat, obviously. And it also can actually wax and wane, to where you may have acute thinking you're getting better, and then if other things trigger it later in life, it can come back. So the diagnosis of PTSD is challenging to do because there is no imaging, laboratory test, or anything like that. It basically is going to be involving the healthcare provider and then a lot of different kind of interviews and self-testing. So you basically have your psychologist or your psychiatrist, and then you've got certain assessment tools that we'll talk about here. A lot of people do try to diagnose themselves. Obviously, that shouldn't be done, and you should go to a healthcare provider, which sometimes is difficult to do because people that have PTSD try to avoid doing that. They just don't want to go seek help. It can occur at any age, even in childhood or as elderly. Certain people are at higher risk. Say recent immigration coming from a third world country. You got a lot of civil war going on in that country. You're obviously going to be at an increased risk for that. In general, though, there is no difference as far as minorities or certain ethnic groups as far as being at an increased risk versus not. You know, so if you're a Mexican and you're born and raised here, you're going to be at the same level as, say, me or anybody else. Now, obviously, if you're coming from a third world country, that's going to be a different scenario. So the onset, as we mentioned, can be immediate or it can be delayed. Immediate onset is going to have a better treatment response. You're going to have a better prognosis. You're going to long-term have many fewer signs and symptoms, less potential complications, and oftentimes you can get this to resolve within 6 months. If it's a delayed onset, meaning more than 6 months, or especially at least more than 3 months, it's much more likely to become chronic. You're more likely to have more severe symptoms and issues long-term, and overall worse prognosis. The duration of the symptoms can also vary. A lot of people do have complete recovery within 3 months, and in fact, about half of the cases are like that in the States. However, there is a fair amount that will go longer than 12 months. You can have, like we talked about, symptom reactivation, meaning that you've had your symptoms, you were labeled with PTSD, you went through treatment, you've improved it, and then months, years later, you can get it back. And that's oftentimes because you just happen to get reminded of the original trauma or certain kind of life stressors, or you actually have a new type of traumatic event that then makes you relive the old one. The severity, duration, and proximity, those are going to be, for the individual, the most important factors in regards to developing the PTSD. So the more severe that traumatic event is, the longer the duration. Say some of the military guides, it's involved, for years across seas. And then also, obviously, the proximity as far as if you're actually really right there, watching your friends and that kind of stuff die. Things such as social support help as far as with treatment. Certain family histories, meaning if you have a lot of mental health issues in your family, that's going to be kind of a bad prognostic sign for you. Childhood experiences, this is also going to be a bad prognostic identifier for you, meaning like child abuse. Those are some of the hardest cases to try to treat and to get the child out of PTSD. If you have certain personality type variables, such as type A personality, they're harder to treat, or any other pre-existing mental disorders. You can also develop in individuals that have no predisposing conditions at all, and this is a lot of our soldiers. Some of the worst ones, though, for us would be human design, meaning child abuse, rape, torture, things like that. So some of the other possible causes, they can be direct, as far as the actual or threatened death or a serious injury, say like the towers that blew up and people actually saw that in New York City. You can have a threat to one's physical integrity. You can actually just witness an event that involved death, so you yourself really weren't a part of it. You can actually learn about it. Say you had a death of a family member that was unexpected. So there's more than just you physically seeing the traumatic injury. So some of the examples of the traumatic events experienced directly are here. Violent crimes, obviously sexual assault, rape, chronic abuse, especially child abuse, the military combat, natural disasters such as hurricanes, kidnapping, hostages, terrorist attacks, torture, incarceration with prison, especially if it's prisoners of war or concentration camps such as the Holocaust, life-threatening illnesses that you yourself might have been diagnosed with cancer. Obviously, in our world would be like MVCs, falls, things of that nature. And then you also can have examples of witnessed traumatic events, meaning that you actually observe it. So you yourself might not have been involved in the car accident, but you observe that, or you unexpectedly, you're not in healthcare and you observe dead body parts or a dead body of something unexpected. That all can trigger it depending on the person. Examples of events experienced by others that are learned. You could learn of a violent personal assault, from a family member or a close friend, or a serious accident or a death. You could actually learn that one of your child has cancer. That can trigger PTSD in yourself. You also can end up getting PTSD easier just because of hereditary. So it's been shown that relatives that have depression, anxiety disorders, and things like that, you're going to be at an increased risk that if you do have a major traumatic event to turn yourself into PTSD, compared to a family that has no mental health disorders in their past. So there's some myths in regards to PTSD. One is that it only affects war veterans. As we've talked about already, that's not true. I mean, it affects pretty much anybody. In fact, it's listed that about 70% of Americans will be exposed to at least some kind of traumatic event in their lifetime. Of that 70%, they suggest that up to 10% may actually go on to develop PTSD. That being said, women in general are going to be much more likely to develop PTSD in their lifetime than a man. Some of that is simply because of abuse. In fact, that's kind of the main reason, which I guess is their physical and sexual assault. And again, these are some of the hardest ones to treat. Other ones that are hard to treat would be not just the domestic violence, but the child abuse. Another myth is that people should be able to move on with their lives after any kind of traumatic event, and if you can't, you're just weak. And that's not true either. Whenever people experience big traumatic events, they oftentimes will have to go through at least somewhat of an adjustment period. Now, most people can kind of get themselves back to normal life, and that trauma doesn't affect them long term. Some people, however, can't. So if that starts to affect your life long term from a functional standpoint, meaning mentally, emotionally, or physically well-being, you have to start to be thinking about PTSD. And research actually has shown that after large, long traumatic events, you do get disruption and alteration in your brain chemistry with certain chemicals such as serotonin, norepinephrine, etc. And for some of these people, then this will change your views as far as how you view yourself and the world around them. So all these kind of things eventually then lead to PTSD. Another myth is that people suffering from PTSD right after they experienced a traumatic event. And that's not true either, because PTSD can't be diagnosed for those first 3 months. If it's within that first 3 months, that's what we'll get to here in a little bit, as far as it's basically just an acute stress disorder. So a lot of people get an acute stress disorder after a major traumatic event. Most people get over that. If that starts, and a lot of the signs and symptoms of acute stress disorder compared to PTSD is the same. As the time starts to wear on and you get past those 3 months, that's where you start kind of relabeling them from the acute stress disorder into more of a PTSD. So what's the prevalence? So in general, it kind of varies a lot. I mean, it's really hard to kind of find an exact number. I've seen anywhere from 1 to 14% for just the general community, up to 3 to 58% for at-risk populations, meaning soldiers and people of that nature, or immigrants coming in from a third world. It's estimated that about 5.2 American adults will have PTSD in their lifetime, so that's about a 3.6% overall. As mentioned, women are going to be twice as likely as men, and about 30% of people from Vietnam have been diagnosed with PTSD. In the Gulf War, it's only 8%. But then if you look way back as far as with World War II and the Holocaust survivors, that's up to 85+%. So what are some of your other risk factors? Some of these we've talked about, but you're more likely if you have a poor social network or not a lot of family around. If you have a family history, previous personal psychiatric history, certain personality traits like type A personality. If you have early separation from your families, so as a child, if you really have a very good child upbringing, you were kind of out on your own early. Poverty, child abuse, other child behaviors like ADHD. If you're limited education, the more education you have, the less likely you are to have PTSD, but also the less likely you are to have it long term. And then females, we mentioned. So what are the 6 strongest predictors of trauma exposure, meaning the most likely that you're going to have some kind of a traumatic event? Well, males, which most of us involved with trauma kind of understand, most of them are males that come in the middle of the night. Absence of college education, if you're extroverted, neuroticism, early misconduct, and then if you have family psychiatric illnesses. So this all increases your risk, nothing with PTSD, but just as far as increasing your risk that you're going to be exposed to trauma in your lifetime. The 6 strongest predictors for risk of PTSD would be female, neuroticism, early separation from your parents, prior anxiety or depression, family anxiety problems, and then antisocial personality disorders in your family. Estimated risk for developing PTSD based on the event. If you have severe beatings or physical assaults, you're about a 31% chance you're going to get PTSD long term with that. Sexual assault, 23%. If you have a severe MVC, fall, something of that nature, 16%. If you're shot or stabbed, you're down to 15%. A sudden unexpected death of a family member, 14%. Child's life-threatening illness, 10%. Witnessing a killing or a severe injury, 7%, and then natural disasters are at 3%. So what are some of the other consequences of PTSD? Well, some are going to be physiological concerns, meaning that people with PTSD can have real physical complaints, and oftentimes they come into the hospitals and we view them as people that have physical problems, chest pain, etc., and we rule out anatomical problems as far as heart disease, etc., and it's negative, and then a lot of times people get sent home. So it's misdiagnosed or underdiagnosed a lot because we don't kind of look into that next realm as far as the diagnosis, because most of us aren't involved with mental health. And I'm probably labeled with that. You get some of these people that come in, we look for anatomical problems, we image them, we lab them, we do all this kind of stuff, and everything's negative, and then we send them home. And a lot of these people aren't just going to, be like, hey, I got beat as a child. They're not going to, just raise your hand and tell you what's going on. You kind of have to dig. And that's kind of why a lot of these people aren't necessarily labeled with PTSD. You also can have a lot of social and interpersonal problems, a lot of relationship issues, self-esteem issues, huge rates of alcohol and substance abuse, lots of problems as far as employment problems, especially with our soldiers. You have a higher rate of homelessness, lots of issues with the law, and much more likely to be isolated. So what's the evaluation? Well, the evaluation is going to be kind of twofold. First off, you're going to have an interviewer. So you're going to basically sit down and have a talk. And this can vary a lot. There's really no good algorithm that I can find or as far as exactly how you go through with this. But it can be anywhere from a 15-minute sit down to 8 one-hour sessions. And some of this has to do with why we're doing it. If people's trying to get disability, if it's a legal issue, you're going to be much more likely to dig in a lot deeper to truly identify, do they have PTSD. Besides the interviews, you're going to have a lot of psychological tests, and there's a ton of them out there. Oftentimes, if you do have family members, they're going to be involved as well. And then also you'll also be examined as far as for physiological reactions, as far as do you truly have issues as far as tachycardia and other kind of physical signs secondary to the mental health disorder or secondary to a physical anatomical problem, such as heart disease. So you're going to have your expert therapist. Those are oftentimes going to be psychologists or psychiatrists, social workers, the psychiatric nurses. The VAs, they're set up pretty well with this, probably better than most other hospitals. They have a lot of PTSD programs. They have certain vet centers that the veterans can go to. And a lot of hospitals or medical facilities do have at least some kind of a clinic affiliation with that. So as we talked about, you're going to have a structured interview, and then you're going to also have a lot of self-reporting questionnaires. So the interviews is with the psychologist or the psychiatrist. The questionnaires are multiple. So from the best I can understand, the best one you can do is this CAPS. In reality, though, it's too complex, it's too time-consuming, it's not practical, and it's not used very often. So the one that they do use more often is the Treatment Outcomes PTSD Scale. It's easier to use, it's less time-consuming, it is more practical, and it's more or less objective as far as with scoring. So if you go through these questionnaires and you score 5 or less, you probably don't have PTSD. 7 is going to be potentially with the mild symptoms, 15 moderate symptoms, 21 indicates severe symptoms. So obviously the higher up you go on your numbers, the more likely you're going to be diagnosed with PTSD. There's also a screening that's easy and fast that primary care physicians can use. And essentially what this is that they ask this question. In your life, have you had any experiences that were so frightening, horrible, or upsetting that in the past month you did any of this? Have you had nightmares about it or thinking about it when you didn't want to? You tried hard not to think about it or went out of your way to avoid situations that reminded you of it. You were constantly on guard, watchful, or you were easily startled. You felt numb, detached from other activities, surroundings, family, and things like that. If you get at least 3 of these things as a positive, that's where you need to then definitely kind of take it to the next level for a formal diagnosis of PTSD. There's a lot of other kind of different interview strategies. This is just kind of a few of them, and they're all kind of the same and kind of different. And way too complicated to get into it today. There's also self-reporting questionnaires. And these are used quite commonly just because of the time efficiency. It's easier to do because the person, they themselves, are the one that's going to be doing it. And again, there's not just one. There's a whole lot of different kind of self-questionnaires that you can do. This is just kind of a list of from what I could find as being some of the most common. And they all kind of help, label you or group you as far as being low, medium, or high risk for PTSD. Assessing children. Now, this is much more difficult because the current diagnostic criteria for PTSD is mostly verbal. You're taking questionnaires and things like that. So young children, they obviously can't talk and express their feelings nearly as well as we can, and they express a lot of it as far as with these nonverbal channels. So it gets difficult at times to assess children with PTSD. Some of the things that you look for is going to be where they act out or where they internalize their behaviors. They have a lot of nightmares or disturbed sleep patterns. They regress. They have very clingy type behaviors. They re-experience the trauma with nightmares, monsters, etc. School-age children, it still can be challenging, even though they can express it. A lot of times they can't express it kind of as abstractly as what they should be able to. So they still have a lot of regression symptoms as far as bedwetting, clingy behavior, they're anxious, a lot of school issues, whether you're fighting, don't want to go, don't pay attention, bad grades. You have fighting with your peers, you're withdrawn, don't have many friends, bad attention span, and then just get bad grades. With the school-age children, they still oftentimes, they can't abstract their feelings as much. So they have issues really identifying, and explaining their anxiety or what they're re-experiencing. So they still a lot of times go back to those somatic disorders as far as, oh, well, my stomach aches, or I have a headache, or something of that nature where they don't want to go back to school. They have sleep issues, they don't want to sleep alone, nightmares, etc. So as the kids get older, then it becomes a little bit easier to diagnose because now you're starting to treat them a little bit more as adults. one of the big things with older children, say teenagers, is where they have a foreshortened future. They really don't care much about school as far as after high school. You know, they don't think they're going to have a good career. They don't want to go to college. They don't think they're going to live as far as a long, normal lifespan. They get into a lot of the alcohol, drugs, not very interested as far as marriage or anything socially. And then with chronic PTSD, this oftentimes can then present with more difficult behaviors as far as suicidal ideation. You have a lot of conduct problems. You have a lot of dissociation issues, derealization, depersonalization problems, substance abuse, etc. So with your child assessment, you need to evaluate both pre and post the traumatic event. And you're going to do this in multiple ways. So one is just direct observation. Another one's going to be the oral report as far as what they can tell you, the interview, the questionnaires, and then also the big thing is who else is familiar with the child, family, close relatives, etc. There's also a lot of other tools that you can use. Again, this is just a short list of them, but there's a lot of checklists that can kind of help you evaluate how bad the child is after the traumatic injury. So with PTSD, you have to start to rule out, though, to make sure that's really what it is, and that it's not some other kind of anxiety disorder. We talked a little bit as far as the acute stress disorder. The big thing there is the duration's up to 4 weeks. So the first 4 weeks, you're kind of in that category before you get to PTSD. Adjustment disorder, that's less severe stressors. And you oftentimes have a different symptom pattern. You also have mood disorders such as depression, and then other disorders such as OCD, schizophrenia, etc. Other ones, dissociative disorders, depression we talked about, borderline personality disorders, traumatic brain injury, which is what we'll talk about here in a minute in regards with the soldiers, and then substance abuse, dependence disorders, and you also have malingerers. And unfortunately, we really have these people, and they take a lot of time and money out of our healthcare system. But they literally want to try to be labeled as PTSD, whether it's for money or for, they're trying to win a court case, whatever that is. And those are sometimes very hard to get out of the system. So in regards to traumatic brain injury, so what is traumatic brain injury? So it's basically damage to the brain from an external force, whether it's a blast, a bullet, something of that nature. And we have a fair amount of soldiers that really have traumatic brain injury. So a lot of people in this day of age have blast injuries just because of all the explosives. You get a big complex pressure wave that's generated from the explosion. Then you have certain issues such as ear problems, lung problems, GI, brain, and then spine problems. Obviously, the closer you are to the blast, the higher your risk of injury. But you're also going to have injury then physically as far as being thrown, debris, and burns. And why do I bring this up? Well, it's because of a lot of our armed forces are getting these blast injuries and traumatic brain injuries. It's easy to treat their injuries acutely, but then as you go long term, that becomes more of a chronic problem, and then you have to start to identify, is it traumatic brain injury or is it because of PTSD? Because a lot of traumatic brain injuries will have motor and sensory deficits, issues with thinking, memory, learning difficulties, behavior issues. They have high rates of suicide behaviors. They have a lot of psychiatric problems. When you correlate that with PTSD, you get a lot of the same symptoms. Emotionally, they're very labile. Problems with attention, concentration issues, amnesia, irritable, anger. They're overstimulated or on edge. They have a lot of social issues and isolation. So you need to kind of decide, is this more of a TBI problem or is this more of a PTSD problem? And they've identified that people with TBI that develop post-traumatic stress disorder, if you remember the event, you're not going to do as well. So those with no memory oftentimes are going to be less likely to get the PTSD. So you've got to, we talked a little bit about this, but we got to rule out some of those other anxiety disorders. One, the acute stress disorder. So it's a lot the same. You're exposed to a traumatic event. And here you have to have at least 3 of these issues. You have to have persistent re-experience of that traumatic event. You have to have avoidance of the stimuli that arouses recollections of the trauma. You have to have a marked symptom of anxiety, increased arousal. You have significant impairment. And then the big, which is all PTSD. The big difference is it lasts 2 to 4 weeks. Once it goes past 4 weeks, that's where then it becomes more common to be labeled as a PTSD. OCD, they both have recurrent intrusive thoughts, but the types of thoughts are different. Thoughts present in OCD usually do not relate to the past traumatic event. With PTSD, the thoughts are always connected to the past event. For the adjustment disorder, with PTSD, the stressor is always a traumatic event. For the adjustment disorder, it doesn't have to be near as severe or outside the normal human experience. So it doesn't have to be quite so severe with the trauma. For depression, again, depression after trauma with PTSD, both may present numbing and avoiding features. The difference is depression does not induce, it doesn't involve hyperarousal or any of those other intrusive symptoms. So that goes all the way back to the beginning of the lecture of having to have those 3 different categories as far as having 1, 2, and 3 different kinds of symptoms. So important to ask all patients with mental health symptoms about trauma, especially women suffering from treatment-resistant depression. So if you're seeing someone, they have a lot of depression, no matter what you're treating, no matter how often you're trying to treat them, what kind of meds you're giving, and it's not improving, you need to go the extra. So why PTSD victims might be resistant to getting help? Well, first, they expect to be able to handle the traumatic event on their own. So that's why a lot of people don't seek any kind of assistance or help, is because they think they should get over it on their own. Other times because they blame themselves for the traumatic event. And that's all too often as far as for rape victims or for the soldiers, to where they have shame for the survival. Traumatic experience is too painful to discuss. They simply want to ignore it. You know, they just want to kind of put it away and hope it goes away. PTSD can make some feelings isolated, making it hard for them to get help. They just simply want to avoid the situation. And a lot of times they don't make the connection that this really may be, the trauma may be giving them PTSD. They just think that's just the way that they are. They just have anxiety, anger, and other kind of problems. And oftentimes, again, they go into depression or substance abuse, so they just don't seek help. Now, during a traumatic event, you do have alterations of certain brain chemicals. 2 of the main ones are going to be norepinephrine and serotonin. So norepinephrine mobilizes fear. It's the flight response, it's the sympathetic activation, and it's involved with memory. If you get too much of this, that's where you get that hypervigilance, the autonomic response, the increased arousal, the flashbacks, and the intrusive memories. For serotonin, it's more of the self-defense, rage, and too little of this, you get a lot of aggression, violence, impulsivity, depression, anxiety. So the problem with the PTSD victims is these things are basically just switched on or off, meaning serotonin goes low, norepinephrine goes up. So what's the treatment? So treatment's going to be individualized therapy, group therapy, and medications. It's oftentimes going to be a multiple modality type of treatment. So you're going to have a lot of initial education with the patient, a lot of support, sometimes referrals onto such as the psychiatrist. The biggest thing is you have to establish trust to begin with for these patients. Oftentimes you do have pharmacotherapy or meds that's going to be involved with this as an initial therapy. Psychotherapy is going to be the mainstay as far as treatment. And then also you're going to have a lot of relaxation type of training, such as hypnosis and relaxing imaging, etc. So for acute PTSD, you're going to look as far as stress debriefing and individual psychotherapy. If it's severe, you're going to start to add group therapy and medications. And then for chronic, psychotherapy is going to be the mainstay to it. And then also in children, adolescents, and geriatrics, psychotherapy is going to be the mainstay of treatment. So there's a lot of different kind of psychotherapy out there that I've become aware of really quick. And it gets kind of complicated fairly rapidly. rapidly. So a lot of these are just some of the kind of the definitions of what this is. So exposure therapy. Basically, you're going to get educated about common reactions to the trauma. You're going to have how do you rebreathe? So you're going to try to retrain yourself as far as when you do get anxious. You're going to be involved as far as with repeated exposure to the past trauma and graduated doses. The goal of all this is to try to remember the event without getting anxious, panicked, etc., and getting your symptoms back. Cognitive therapy, that's going to be one of the mainstays of your psychotherapy, and that's where you're going to try to separate the intrusive thoughts from the associated anxiety that they produce. And then stress inoculation training, this is a variant of exposure training, teaches the patient to basically relax. So for the cognitive behavior therapy, what this involves is that you're going to teach and reinforce self-monitoring of thoughts and emotions. You're going to try to identify autonomic thoughts that accompany distressing emotions. You're going to learn about different types of cognitive distortions, and you're going to work to dispute the distressing enhancing cognitions. So it's been shown that for cognitive behavior therapy, especially women who don't drop out of these kind of treatments, because there's a high rate of dropout with this, that it's the most successful, it's highly effective as far as getting PTSD into remission and to also decreasing your symptom severity at the least. So this is the mainstay as far as psychotherapy. Medications, SSRIs are a big one, such as the Zolofts, the Paxils, Prozacs, etc. And this affects basically serotonin. It may reduce your depression, intrusive and avoidance symptoms, anger, outbursts, hyperarousal symptoms. And these are all FDA approved for the treatment of just anxiety disorders in general, including PTSD. Your tricyclics, those also are FDA approved. And this not only affects your serotonin, but it also is going to affect your norepinephrine. And this is going to try to reduce your insomnia, the dream problem, anxiety, guilt, flashbacks, and depression. You want to have at least an 8 to 12 week duration of these medications. You want to adjust them up as needed. If they start to work and improve with your symptoms, you want to run it at least a year before you kind of feel like where you're going to be at for a baseline. And these are just some of the mainstay as far as the medications. This is just a list of the doses. So you want to basically start low and then advance up, even up to the max dose if needed. In regards to individual psychotherapy, you're going to have the crisis intervention. That's basically where you're going to try to establish rapport and promote acceptance. So that's kind of the initial treatment. There's also a trauma-focused psychotherapy and then an implosive therapy. This is basically behavior therapy that's going to be involving intense recollections in review of anxiety-producing situations or events in an attempt to develop a more appropriate response to similar situations in the future. So a lot of the psychotherapy is trying to reduce your signs and symptoms and try to prevent the bad exposure from the initial insult. One of the other big ones as far as with psychotherapy is the systemic desensitization. I know there's a lot of words there, but basically you're going to try to reduce the anxiety through counter conditioning. So you're trying to teach to replace those feelings of all those anxiety with relaxation. So a good example is you got a fear of dating a woman. So you're going to try to make a hierarchy of your anxiety. So what gets you the least anxious up to what gets you the most anxious. So say for a college kid, you're trying to sit next to a woman in class, then you want to try, and then it makes you more nervous to talk to her, to walk with her on campus, talk on the phone, eat a meal, and then eventually go out on a date. So what the therapist is going to try to do is start out with relaxation techniques and use these relaxation techniques for that anxiety. You're going to start with the least, and when you improve with this, then you're going to eventually go down, and the goal is to eventually get to where you can go out on a date with women without getting the anxiety. If things are bad, you always can resort to hospitalization. In children, FDA-approved medication-wise is pretty much Prozac and Zoloft. Again, cognitive behavior therapy is going to be the staple of it. They do add play therapy, which is going to give you a lot of different kind of play and creative arts techniques to try to alleviate a lot of those psychological and emotional conditions. Again, one of the biggest things besides the psychotherapy, what you involve with that is going to be parental influence. So family, support system, etc. is very important. So towards the end here of the talk, basically looking at dealing with anger and irritability. So this is a huge problem, especially for people trying to get back into society. So you've been labeled with PTSD, you've had a lot of problems, say you were over in the war, and now you're trying to, back in civilian life and you're trying to get back into the workforce. A lot of these guys have issues because of anger, irritable, and things like that. And then how can we try to improve that? So over the next few slides, this is just how do you try to improve these people to get back into society. One is they have a lot of lack of concentration issues. So you can try to reduce distractions, provide private spaces for them to work, allow them to have headsets or music to where they can kind of get into their own world, reduce or increase lighting, divide large assignments up into smaller assignments, try to plan uninterrupted work time. A lot of times they have issues as far as with supervision. So things that you can work on from an employer standpoint is give information in writing, not always in verbal. Provide detailed daily feedback and guidance. Provide a positive reinforcement. Give clear expectations and also consequences. And then also develop strategies together for dealing with conflict when they arise. A lot of people have issues as far as with coping with stress. So try to give them longer and more frequent breaks, additional time for new responsibilities, restructure their duties during times of stress, give them time off for therapy, and then try to assign them to a mentor or a supervisor. Many of these people have issues also interacting with coworkers. So things that you can try to improve would be encourage the employee to walk away, allow employees to work from home part-time, provide partitions or closed door for privacy, provide disability awareness to the other coworkers and supervisors. Many people have issues as far as dealing with emotions. You can try to refer them to the vets or the mental health centers if they haven't been there already. You can use stress management techniques, allow for support animals, allow for telephone calls during work hours to doctors and counselors, and then give frequent breaks. Many have problems with sleep disturbance, so you can try to allow employees just one constant or consistent schedule, allow for flexible start time, combine regularly scheduled breaks into like one longer break, and provide a place for the employee to sleep during a break. Absenteeism is another huge issue. You can try to allow for flex time, allow them to work at home, provide a straight shift or a permanent schedule, so they're not rotating a lot. Count one occurrence for all PTSD-related absentees. We probably couldn't give that for the general public. Allow the employee to make up for missed time. For panic attacks, allow for a break or a place to go to use for relaxation when panic attacks occur. Give a support person, identify and remove environmental triggers, and then again a support animal. So what's the overall prognosis? So with PTSD, about 30% are going to recover completely, and this is for all comers. 40% are going to be reduced to just mild symptoms, and most all these people are still able to function in society fairly well. 20% have moderate symptoms, and 10% are unchanged or worsen over time. If you have issues with startling, nightmares, irritability, depression, these things can often worsen over age, meaning as time goes on. And then oftentimes people that don't get better end up getting other psychological comorbidities such as major depression, OCD, panic, substance abuse, etc. So for points to remember, if a patient has multiple complaints, think PTSD or at least a personality disorder, an anxiety disorder. Dreams is a good little thing to remember as far as detachment, re-experiencing the event, emotional effects, avoidance, month in duration, because before that it's acute stress disorder, and then hyperactivity and hypervigilance. And then this is just going to be a simple questionnaire that you can use to screen some individuals. And I think that's it. Yep. Questions?
I think we use the very similar, same approach that you suggested, which is really when we see patients in the emergency department or an inpatient unit or an outpatient unit, you're going to be evaluating three-prong: observation, clinical interview, and collateral information. And part of the clinical interview is to ask questions or do a self-check. We don't do, we do the O230, but that's because a lot of the patients that we see are pretty severe. So there's 30 questions pre and post. They give us a good sense of what's going on for that patient. They do recover very quickly. We had one gal that had 240 inpatient days in a year and had chronic PTSD. And we were able to develop some services around her that helped her start dealing with it. A little bit more exposure therapy and the cognitive behavioral stuff. And actually today she has maybe one or two seeks out medical attention. So it's getting the right providers.
Mm-hmm.
Appreciate it.
No problem. Thanks, guys.